So now let's proceed to the bleeding disorders. So bleeding disorder, when will be there? So starting from the vessel, the platelet, primary hemostatic plaque, and the secondary fibrin clot. So any of this is defective, then the bleeding disorder is going to manifest. So firstly, we have the vascular disorders. So under vascular disorders, it is going to be usually some kind of vasculitis which is weakening the vessel wall and causing the breakage of the vessel. So vasculitis can result in bleeding disorder. Apart from that, we can have scurvy. So vitamin C, amyloidosis, Ehlers-Danlos syndrome. So in this, collagen is going to be defective, right? So collagen, elastin is going to be defective. So blood vessels will not be formed properly. They are going to be easily ruptured. So that will cause bleeding. Amyloidosis, again, the deposition of amyloid is going to be most commonly around the blood vessels, right? So that will cause weakening of the vessel and that will lead to bleeding again. So whenever there is a vascular kind of pathology leading to bleeding disorder, the clinical features will be bleeding as such, but the usual findings will be purpura, ecchymosis, and hematoma formation. So purpura is nothing but small blotches of bleeding will be there, and then slightly larger blotches are called as ecchymosis. So ecchymosis is nothing but the contusion we see, right? So any blunt trauma is you will get a contusion. So this contusion, ecchymosis is seen in vascular pathology, and then again hematoma. Hematoma is again a localized collection of blood clot. So purpura, ecchymosis, and hematoma is there. If they given the history, they are mentioning to a vascular pathology. Then coming to platelet disorders. So platelet disorders could either be related to the platelet number or the platelet function. So whenever platelet number is going to go down, that is thrombocytopenia, it is going to cause bleeding disorder. So normal count less than 1.5 lakh, if it is going to cause platelet disorder, platelet bleeding disorder. Function also, if it is defective, it is going to cause bleeding. So first let's see the platelet number, thrombocytopenic disorders. So whenever there is going to be a decrease in the platelet, the bone marrow is going to try to compensate for the decrease in platelet. It is trying to produce more and more of platelets. So in that case, the bone marrow is going to have lots and lots of megakaryocytes, which is the precursor for platelets. So there is going to be megakaryocytic proliferation. So those kind of thrombocytopenia you are going to call as megakaryocytic thrombocytopenia. In some certain conditions, the bone marrow is also affected. So the bone marrow stem cells, the megakaryocytes, are going to be affected in the sense they cannot produce platelets. So the source is also defective and the periphery in the platelets are also going to be defective. So that is called as amegakaryocytic thrombocytopenia. So under megakaryocytic thrombocytopenia, we have two mechanisms basically, immune mediated mechanism and a non-immune mediated mechanism. So in immune mediated mechanism, there is going to be some kind of autoantibody or some immune mechanism in which the platelets are being destroyed. In non-immune, nothing as such is there, but the platelets are going to decrease. So under immune megakaryocytic thrombocytopenia, we have the examples of immune thrombocytopenic purpura, ITP, then SLE. In SLE, again, you are going to have autoantibodies formed against the platelets. Then in dengue fever, it is usually the platelets are going to be specifically attacked by the flavivirus. Then certain drugs again can cause the thrombocytopenia. Then under non-immune megakaryocytic thrombocytopenia, you are going to have the microangiopathic hemolytic anemias. So in microangiopathic hemolytic anemias, there is going to be consumptive coagulopathy and thrombocytopenia. So there is going to be consumptive thrombus is going to be formed. So when lots of thrombi are being formed, the platelets are being consumed. That is going to lead to the decrease in the platelets. Okay, as such, there is no immune mechanism involved in this. So the examples of microangiopathic hemolytic anemia will be hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and disseminated intravascular coagulation. So HUS and TTP will be discussing in the RBC, while DIC will be discussing here. So these two are the megakaryocytic thrombocytopenic causes, while amegakaryocytic thrombocytopenic causes will be wherein the bone marrow has been infiltrated by something or the bone marrow megakaryocytes is going to be decreased. The stem cells are going to be affected. So in case of aplastic anemia, so all the stem cells are being affected. So all the lineages, RBC precursors, WBC precursors, and the platelet precursors, all of them are going to be deficient. So Aplastic anemia is an example of that. Then if the bone marrow is being infiltrated by certain other cells like leukemic cells, lymphomas, or any other metastasis coming to the bone marrow, so all of this is going to occupy the bone marrow, reducing the space for the bone marrow hematopoietic cells. Okay. Then other than that, we can also have fibrosis in the bone marrow. So like hairy cell leukemia or any MDS or myelofibrosis. So in this kind of picture, this fibrosis will be there, which is replacing the entire bone marrow architecture. So again, the stem cells are going to be decreased here. Then we have alcohol, which is going to be directly toxic to the megakaryocyte also. So alcohol can cause decreased megakaryocytes. Then HIV infection, same goes for that. So there is going to be decreased platelets again in that. So this is related to the platelet number decreasing. If the platelet function is going to be defective, so there are certain examples in which the platelet functions are defective, leading to bleeding disorder. That is Bernard-Solier syndrome, Glanzmann's thrombasthenia, and then we have von Willebrand disease. Okay. So the third part of this bleeding disorder will be related to the final coagulation cascade, which is the fibrin clot formation. So any deficiency of the coagulation factors will in turn again lead to the bleeding disorder. So a clotting factor deficiency causing this coagulation factors. So generally, in general, I am speaking, if you see in any vascular pathology, if you check for the coagulation profile, so BT, platelet count, PT, APTT, these are all going to be normal because the platelets are normal, coagulation factors are normal. So all of this will be normal in a vascular pathology. While in platelet related disorder, in platelet number deficiency, this here it is going to be platelet count will be decreased in this, while BT will be elevated, while PT and APTT will be normal in this, right? In platelet function disorders, here the platelet count will also be normal, but BT will be elevated since platelets are affected. Then PT and APTT will also be normal. Okay. In coagulation factor deficiency, it is going to be platelet count will be normal. So BT will also be normal here. Apart from that, here the PT and APTT based upon what kind of clotting factor is deficient, like whether the intrinsic pathway is affected or the extrinsic pathway is affected. So PT and APTT is going to be abnormally elevated. Okay.